Hi guys.
Hi.
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 Okay. Today we are going to just do the Brentwood and let's see what we learned from it. We did very good in our cases. Uh, Hopefully we'll learn more from the Brentwood. Let's see. You guys ready?
Yeah,
Yes.
okay.
Yes. Okay. All right. Let's start. Mm, Okay. So you can see my screen, right?
You can see.
Okay. Good. Um, so this flow cytometry, can anyone interpret what's going on in here? Anyone?
There are orange color cells that
Mm-hmm.
are CD45 dim, almost negative,
Mm-hmm.
and they have a they are CD20 and CD5 negative, and they're CD56 positive.
Mm-hmm.
So yeah, that's
So what do
what
you
I
interpret
can
from
say.
that?
So they could be NK cells.
Well, they haven't shown 16 here, and they haven't shown 7 and the other epsilon cytoplasmic CD5. So if they were talking about that, they would have shown other things as well.
Very good.
Let me mute. There is someone who is talking. I'm muting all. Sagrika, you can unmute yourself.
So
Yeah. So there, what they are showing here is you can see that first, as you said, was very correct that the CD45 is very dim, and that's something that's unusual. You can see CD5, CD20, that's dim as well, and that's negative as well. So it's not B lineage. They're not showing the other B cell markers, but still, like with this much, it's not B lineage. It's not having the CD5, not the T lineage marker. They are showing over here this EpCAM and then CD56. EpCAM we don't have, but CD56 bright, it's almost going to the roof over here. So there, this case they are saying it's a small cell carcinoma, so non-hematopoietic neoplasm consistent with small cell carcinoma. This is not a hematopoietic, and I have seen many cases of small cell carcinomas on the lymph node and others that are flowed, and they show bright CD56. They are negative for CD45. They are negative for B and T cell markers, and they are actually small cell carcinomas that that are in the flow cytometry. So you can still detect the small cell carcinoma in the flow cytometry, and that sometimes is causes confusion. Like if you start thinking it is hematopoietic, that will cause confusion right there. So let's see. So here they are clinching all of the diagnosis over here. So they are saying that this patient has a right lung mass and several masses in the mediastinum, neck, and liver. FNA of this lymph node is performed, and portion of the sample is for flow cytometry. So here they are saying the same things in the explanation. So this is all is all viable cells, and then no B or T cell population was identified. However, flow cytometry demonstrates dominant population of cells in orange of intermediate size by forward scatter that lack 45 and markers of BNT. The abnormal cells express 56 as at a very high level, that is off scale, and with EpCAM suggesting a non-hematopoietic neoplasm, and that's a small cell carcinoma. So, and then flow cytometry is very well established as a tool for evaluating hematopoietic. However, the use of technology in evaluating non-hematopoietic is limited. Early uses of flow cytometry to evaluate non-hematopoietic neoplasms focus on assessment of DNA ploidy for prognostication in the known carcinomas. Um, Descriptions of flow cytometry for diagnosis of non-hematopoietic are less frequent. However, literature in this area is growing. Several groups have evaluated flow cytometry in the diagnosis of non-hematopoietic in the setting, including evaluations of effusions, evaluating a variety of samples from the neuroendocrine neoplasms. In addition, flow cytometry has been found useful in identifying non-hematopoietic metastatic sites to include the marrow and lymph node. Antigens most commonly used in evaluating non-hematopoietic include CD45, EpCAM, CD56, and CD138. CD15 and 10 may also have a role in these markers as expressed on some carcinomas and can be evaluated by flow cytometry. CD45 is expressed with increasing intensity on most of the hematopoietic cells. So that's your first clue with maturation, right? And the presence of expanded CD45 negative cells with the forward sites and site scatter characteristic of large cell can raise that it is a non-hematopoietic neoplasm. However, CD45 is typically negative on the erythroid cell. So that's something, that caveat you have to remember, and may be absent on the hematopoietic, some of the hematopoietic, and those are including plasma cell neoplasms, followed by acute leukemia, occasionally lymphomas as well. Therefore, the absence of this other markers present on the hematopoietic cells should be demonstrated on CD45 populations prior to entertaining a possibility of non-hematopoietic neoplasm. Such markers will include the myeloid markers, so 33117, the blast marker, and the monocytic markers, to exclude the blast or immature monocytic, and then 1920 to exclude the B cell, and then 3 and 7 to exclude the T cell. So that will be your clincher towards the diagnosis at 45 negative and all the BT and myeloid markers negative, monocytic markers negative, stem cell markers negative. Evaluation of CD38 is recommended to exclude. So whenever you have a CD45 negative population, they are saying that you should evaluate CD38 to exclude the plasma cell population. As plasma cell neoplasms will be negative for each of the aforementioned antigens, and may express 56 and 138 that can be seen in the non-hematopoietic neoplasms as well. Similar to neoplastic populations of non-hematopoietic cells, a normal non-hematopoietic cell often share the feature of large cell size as compared to the lymphoid cell and lack 45 and other hematopoietic markers. Therefore, before suggesting a non-hematopoietic, expression of a more specific marker by abnormal population is desirable. This is particularly true in specimens such as effusions, which may contain significant numbers of normal non-hematopoietic cells such as mesothelial cells. Markers that has been investigated include EpCAM and CD56. So EpCAM, now they are coming to the epithelial CAM, is a transmembrane glycoprotein expressed by variety of human epithelial cells that function as an adhesion molecule. With the exception of adult squamous epithelium, this marker is also expressed as the basolateral membrane of most of the epithelial tissues. This marker is overexpressed in number of carcinomas, allowing it in use of diagnostic of non-hematopoietic neoplasms. However, this marker is also expressed in higher levels in the proliferative tissues, including intestinal epithelium of the colon, hepatocytes, and fallopian tubes. In evaluating EpCAM, the BUR-EP4 with CD45 in identifying epithelial neoplasms in the serous effusions and peritoneal washing samples. The majority of the morphology benign samples have no EpCAM positive detected by flow cytometry, while majority of the cytologically malignant effusions showed EpCAM positivity. However, caution is warranted as subset of benign cases showed EpCAM positive cells as well. So those benign cases including the epithelium of the colon, hepatocytes, and fallopian tubes, and so forth. Such false positive results were thought to be secondary to presence of EpCAM on subset of the normal epithelial cells. An increased specificity was achieved when using EpCAM in other conjunction with other markers. However, this is difficult in the clinical practice, given the lack of adequate commercially available conjugated antibodies. Of interest, there is some gene expression data suggesting EpCAM are lower in nodal metastatic tumors as compared to the primary tumors. So CD56, also called as neural cell adhesion molecule is expressed on the various variety of hematopoietic cells, including normal NK cells, neoplastic plasma cells, and some reactive or neoplastic myelomonocytic cells. In addition, this marker has been demonstrated to have utility in identifying non-hematopoietic neoplasms, specifically neuroendocrine neoplasms. And that's the most common one that I have at least seen, the malignancy or non-hematopoietic malignancy identified by flow cytometry. Several retrospective studies have demonstrated that tissue biopsies and FNAs that are involved by neuroendocrine tumors typically show evidence of larger cells expressing 56 without 45 by flow cytometry, suggesting a high sensitivity for flow cytometry using 45 and 56 to detect the neuroendocrine tumors. Additionally, flow cytometry using combination of antibodies, including 45 and 56, has been demonstrated to have high specificity for detecting bone marrow samples involving metastatic neuroblastoma. However, sensitivity of this assay is usually less, as seen in IHC. Of note, one note of caution in using 45 and 56 to aid in detecting neuroendocrine tumors is that plasma cell and some monocytic leukemia will have similar pattern. Therefore, it is critical to exclude the hematopoietic using 38 and the other monocytic markers, so 4, 64, and 33. Other markers typically considered hematopoietic markers that may be expressed in carcinomas. So these can be expressed in carcinomas too, 138, 15, and 10. CD138 expressed in wide variety of carcinoma, but is typically negative on reactive mesothelial cells. Similarly, 15 and 10 has been described in variety of carcinomas. In summary, but I mean, I haven't seen personally cases of carcinomas that are detected by flow cytometry, so I don't have much experience in that. In summary, flow cytometry has utility in diagnosis of non-hematopoietic neoplasms. Flow cytometry is particularly helpful in identifying neuroendocrine tumors and in suggesting involvement of effusion by non-hematopoietic neoplasm. However, several potential pitfalls exist. Therefore, although flow cytometry may suggest non-hematopoietic neoplasm, correlation with morphology is required for definitive diagnosis. The sensitivity and specificity of this modality for detecting non-hematopoietic neoplasm appear to increase with addition of specific markers and list of available markers, including some cytokeratins. So they are also looking into cytokeratins by flow cytometry. With additions of markers to the current repertoire available for evaluating non-hematopoietic neoplasms by flow cytometry, the role of this technique both in primary diagnosis and staging will likely expand. Okay. So then take-home points, non-hematopoietic neoplasms may occasionally be identified by flow as this population of the larger cells lacking 45. Neuroendocrine will express 56. EpCAM expression by flow cytometry may be helpful for the epithelial origin, and this is important. CD10, 15, and 138 can also be present in the epithelial cells. Interesting. Does anyone have EpCAM in their institutes?
So we have EpCAM basically like Burr. We have
EP4, but
Burr.
do they have do you have by flow cytometry?
No, by IHC.
Yeah, right, exactly. Yeah.
Yeah, nowadays for like even like when sometimes they are keratin negative, like my attending say to do Burr and mock for to
Yeah,
for-
yeah. Yeah, I mean that's a usual for like your effusion specimens as a IHC, but in flow cytometry, these cytokeratins or EpCAM, I haven't seen and like I don't have an experience with EpCAM. Like by flow. Yes.
Akansha, you know,
Dr.
these neuroendocrine tumors may express CD56, but then CD10, CD15, CD138 may also be present. So,
Right.
is there any percentage of CD10, CD15, CD138, which is a more predominant?
I do not have I do not have an answer for this. If someone has an answer, they can explain. But I do not know if what's the difference between CD10, 15, and 138 expression between the neuroendocrine cells and the hematopoietic cells. I do not know this answer.
I see. Thank you. No, I was
neuroendocrine or like the carcinomas? I've never seen a case of neuroendocrine expressing 10, 15, 138. Carcinoma, yes, but at least I have not seen a case.
Mm-hmm.
Thank you. Thank you.
All right, ready to go further? All right. So now they are going into myeloids that are somewhat harder to like those harder cases that Raji showed. I personally find myeloids anyways a little challenging. Okay, so let's interpret this flow. And does anyone wants to chime in? It's okay if we are wrong. That's fine. I mean, I haven't read this whole thing as well. So I I am as naive as you are. Anyone? Okay, let's see what they are doing here. So we know this over here in the top is they are writing blast. So these are blast populations. These are all the viable cells. And over here they are writing the myeloid. So this probably is a myelomonocytic or myeloid tube. So blast, they are positive for 34. And they look like they are positive for 38 as well. There is a variable positivity and there is subset that is positive for HLA-DR. And there is aberrant expression of CD7. That's what they are showing over here. So that's aberrant CD7. Over here, so this orange population, I believe could be, so it has higher site scatter. So it is higher site scatter than, so these are the granulocytes as we know, like there is 16 that is expressed. So this orange population with higher site scatters, it could be eosinophils. And let's see, so this 13, usually this 13 should be a little bit over here. So I think this 13 is expressed more than usual over here. And then this 16 would be the more mature cells. And then these cells have high 64. So I think they are bright in 64, which should not happen with the granulocytes. And then they are 16 over here. So they are also they are expressing 14. So that's something that's abnormal too. Like granulocytes should not have that much of 14. So let's read what they are saying over here. Upper left panel shows all viable cells, and then remaining upper panels show all the blasts. The lower panel shows all the myeloid cells. Lymphocytes are colored blue over here, so brightest 45 and low side scatter. Maturing neutrophils, myeloid forms are colored green, and eosinophils are colored orange, right? And then 34 blasts are colored red. Upon review, the CD45 versus side scatter plot, one can see the major subset of myeloid cells show markedly reduced side scatter. So first thing that they have shown over here that this green population, some is here, but this green population has reduced side scatter. So why they are saying that is because the hypogranular, so they are coming to that. And leading to subset of myeloid cells present in the area of 45 versus side scatter, typically that is seen in the monocyte gate and the blast gate. And then by flow cytometry, 34 myeloid blasts comprise 5.6% of the WBC, show aberrant expression of several antigens, including increased and uniform 38. So there is increased 38, decreased HLA-DR, yes. So some of the subset is negative for HLA-DR, and strong uniform CD7. The myeloid forms, lower panel, in addition to major subsets with decreased site scatter, show abnormally increased 13. So that's what I was coming to, that these precursors have abnormally increased 13 and on the maturing forms, and then leading to alteration of normal 13 versus 16. And then there is a retention of 64. So that's what I was coming to, that there is brighter 64 in these myeloid forms. And then again, there is increased CD14 expression. The combined clinical, morphologic, and immunophenotypic findings are diagnostic of MDS, best classified as refractory cytopenias with multilineage dysplasia. Given the history of chemotherapy for carcinoma, so now even if it is a MDS, if there is a chemotherapy history or treatment radiotherapy history of a prior hematopoietic or non-hematopoietic neoplasm, it will be classified as therapy-related myeloid neoplasm. And then we read in our yesterday's session, not yesterday's, the session that we had before, that these therapy-related myeloid neoplasms can be presenting as MDS, can be presenting as AML, with MDS being most common presentation, if you remember. 70% being MDS presentation, and they will be more of 5 to 7 years after the therapy. And the second presentation would be the AML presentation, which has more of MLL kind of 9/11 kind of things, and those will be acute. So basically, AML, we can remember that it is more acute. So it is 2 to 3 years after therapy. So that's and then MDS, therapy related MDS or therapy related myeloid with MDS features will be having those MDS mutations as well. So 5q, 7q, and so forth. So those are the most common mutations of the therapy related MDS. So that's a little bit of what we read earlier. So let's see. They have 73-year-old woman presenting to primary care physician with 6 months of progressive fatigue. Now, she also has recently developed early bruising. So they are coming to that there is low platelet count, so cytopenias, and fatigue with anemia. Her past medical history is relevant for diagnosis of breast carcinoma. So they have given this, for which she was given chemotherapy and radiation. And then the physical exam is unremarkable, but CBC shows pancytopenia with WBC count of 3000. So they are clearly saying that there is pancytopenia with neutropenia and anemia and thrombocytopenia. Bone marrow biopsies performed and show megakaryocytic and erythroid dysplasia with less than 5% of blasts. The proportion of the aspirate is sent for flow cytometry. So it's not a EB1, it's a usual MDS. So MDS best classified as refractory cytopenia with multilineage dysplasia. So myelodysplastic syndromes are clonal stem cell neoplasms that are characterized by ineffective hematopoiesis leading to cytopenias, typically in the setting of hypercellular marrow. The diagnosis of MDS is multifaceted and traditionally has involved by combination of hematology to demonstrate cytopenias, morphology to have dysplasia, cytogenetics that will confirm the diagnosis. However, morphology is not always straightforward, and conventional cytogenetics is uninformative in approximately half of the de novo MDS. Therefore, additional objective tools are also needed. Traditionally, flow cytometry was used in MDS primarily to establish the increase in the blast percentage. However, with advances in our understanding of normal and abnormal maturation, flow cytometry is emerging as a useful tool in the diagnosis of MDS and other myeloid stem cell neoplasms. Many studies have described the potential utility of flow cytometry in evaluating MDS, and this topic is subject to several reviews. Studies for flow cytometry in MDS have varied widely in the method of sample preparation, gating strategies, and number of parameters evaluated, with some studies focusing on single parameter on the single population, while other studies employ methods evaluating a variety of parameters on multiple myeloid populations. Almost all studies have demonstrated that flow cytometry is beneficial in the evaluation of MDS. However, lack of standardization in the field, coupled with need for detailed understanding of myeloid maturation patterns, has delayed the translation of this useful modality to most clinical flow cytometry laboratories. So this actually detecting as to which antigen is brighter than normal, which antigen is dimmer than normal, this requires very well the knowledge of maturation patterns. And what what many people do is they compare with the normal. They do have a normal flow cytometry plot and like a normal template of flow cytometry plot, or else they run normal in each and every run of theirs in flow cytometry. And then they compare these expressions with the normal patterns, and that's how they know that, okay, this is not lying where it is. For example, all those signs that we were talking that Raji has told and taught and everything. So those can be seen in normal, and when you compare it with the normal, you would know that, okay, this is not where it should lie. sometimes, I mean, it becomes hard to remember everything that we have learned. So I found this approach very helpful, just to compare with normal and see, okay, this is not where it should lie, and this is abnormal. So given the heterogeneity of approaches, several groups have produced consensus document for evaluation of MDS by flow cytometry in an attempt to bring standardization to this complex and rapidly growing field. The utility of flow cytometry is now recognized in 2008 WHO, which states the presence of 3 or more aberrant features. So that's their now uh, kind of a definition, like not completely defined, but still highly suggestive. So 3 or more aberrant features and by flow cytometry is highly suggestive of MDS and should be followed up even in the absence of morphologic and cytogenetic criteria. So that's why it is important to have flow evaluation for MDS. And the approach applied in our laboratory is based on pattern recognition. Flow cytometric data for myeloid progenitors or blasts and myelomonocytic cells are reviewed in standardization fashion. 5 classes of antigenic abnormalities are commented. So deviation of myeloid antigenicity, that is intensity, that is 1/3 decade on a log scale in 10% of the cells of interest. So that 10% still is holds true here. That is true for our MDS detection tool, like for our calling it as as multilineage dysplasia, you need to have those dysplastic cells in 10%. So that holds true here as well. Abnormally homogeneous antigen expression. So again, we know that if a blob is sitting homogeneously somewhere, then it's abnormal. And asynchronous. So there's asynchronous expression of 2 myeloid associated antigens. Aberrant expression of myeloid antigens on at least 10%. Again, so they are saying 10% of the population of interest. Aberrant expression of non-myeloid antigens. So again, like CD7 and the others, like. And then granulocyte hypogranularity, so that they were coming to that site scatter is decreased. Then cases are then categorized as flow cytometry normal, indeterminate, or abnormal based on the number and degree of abnormalities present. In a study evaluating this approach, with negative cases showing no abnormalities, most flow cytometry intermediate cases show 3 or fewer mildly abnormal and myeloid antigens and no more than 1 non-myeloid antigen. And most flow cytometry abnormal cases show 5 or more myeloid aberrancies, abnormalities, and 1 or 2 uh, non-myeloid antigens. Flow cytometry showed sensitivity and specificity of 89% and 88% in detecting MDS when considering flow cytometrically abnormal cases. In current case, abnormalities are seen impacting myeloid blast and also maturing myeloid forms. Several reproducible flow cytometric abnormalities have been described in MDS. No single flow cytometric abnormality is diagnostic of MDS. Rather, as MDS can impact all the myeloid lines, a multifaceted approach looking for various abnormalities on many different cell types, blast, maturing myeloid forms, and monocytic cells are required. The greater the number of abnormalities present, the more specific abnormal flow cytometry is for MDS. An understanding of normal myeloid maturation will be critical. Okay. Nidhi, you here, right? Nidhi?
Yes, I'm here, Akanksha.
Okay. Do you want to quickly summarize this chapter?
Sure. Okay. Even I can go back just like I wrote like 3-4 points for the previous one if you want.
Oh, good. I thought that you came late. Okay, let's start from here then. Okay, let's start here.
Yeah, I missed this one. I started when you were reading about CD45.
Okay.
Okay, so CD45, it's basically like a hematopoietic lineage marker. It's usually expressed with increasing intensity on maturing hematopoietic cells. However, it is not expressed on some erythroid cells. We are up till now we are talking about normal hematopoietic cells. So that since it's a marker of hematopoietic lineage, that's why like if in any fluid or any like tissue evaluation where you do CD45 if we are expecting CD45 a hematopoietic neoplasm. However, this doesn't always hold true because CD45 is not expressed on some hematopoietic neoplasms, such as plasma cell neoplasms, some acute leukemias, some lymphomas. That's why they say it should be used in conjunction with other hematopoietic markers like CD33, CD33 for myeloid, CD64 for monocytic population, and with other markers like 34 and 117, which are one more in myeloid, 19 and 20 for B cell, and 3 and 7 for T cell. And for plasma cell, use CD38 and 138 for plasma cell neoplasms. They also
But
say,
again, 138 is something for carcinomas. They have said that 138 can be positive too, right? Yeah. Go ahead.
then they said they talked about two markers, EpCAM and CD56. EpCAM is basically like it's a transmembrane glycoprotein, which is basically expressed by epithelial cells, and it functions as an adhesion molecules. It is expressed in normal epithelium, but it is overexpressed in most of the carcinomas. And its clone, which is mostly used, is BAR-EP4. So if we use it in conjunction with CD45, it can be used for differentiating carcinomas from hematopoietic neoplasms. Then CD56, it's a neural cell adhesion molecules, and it's expressed in neuroendocrine tumors. So we can use it in conjunction with, because those can also be like round blue cell tumors. So if you'll use it in conjunction with CD45, 56 and 45, it can help in detecting neuroendocrines. But again, like practically, like this should be used in conjunction with other markers, because even 56 is expressed, as we have read, in a couple of hematopoietic neoplasms too. What do you, does anyone remember? There's a new neuroendocrine marker, ILS something. I'm forgetting.
That's INSM1.
ILSM1, yes.
INSM1.
INSM1. Okay. Yeah, because we read a article, we read a journal, we had a journal club, then that when synaptophysin and chromogranin and 56 are not leading in anywhere into the diagnosis, then you can use that marker. I think that was like 2 years ago. Now we use that in-house, and it has proved helpful in many cases.
That's nice.
Yeah.
Yes, and it's far more positive and specific for that. And it's actually, it stands for insulinoma associated protein 1.
Okay.
Very good. I don't have that marker in my institute yet. That's nice.
We have it here.
Nice, nice. Very good. Okay, go ahead.
Yeah. Okay, so then they talked about that how CD138, CD10, and CD15 can also be expressed on various epithelial tumors on carcinoma. So like, be cautious, just and don't rely on one marker for detecting any kind of, for categorizing into any kind of neoplasm. That's it for this chapter.
Good. Okay, let's go to MDS.
Okay, so MDS, let's start with this flow case. So we had this man who had we had this woman who had a breast carcinoma, was given chemotherapy and radiation, and then her physical exam on her CBC, she had leukopenia, pancytopenia with leukopenia, WBC 3000, and neutropenia, neutrophil 950, and yeah, and basically had pancytopenia. The blasts were less than 5%. Coming to the flow, on the first plot, CD45 versus side scatter, we have a blue population as lymphocytes with highest CD45. Then we have, so technically, we should have myeloid with high side scatter, but we see myeloid right next to the lymphoid, where in the monocytoid gate with decreased side scatter. So basically, we are seeing that there is some kind of aberrancy here. Okay, going to the next plot in the same row, we have blasts here. These blasts are positive for CD34 and 38. They have high expression of 38. Then going to the next plot, the blasts are again positive for 38, 34, but they are showing like a decreased expression of HLA-DR. There's a spectrum of HLA-DR, like HLA-DR expression, it's decreasing on them. So that's kind of weird too. Then the blasts have an aberrant expression of have an expression of CD72, which is aberrant. If we'll go further, we'll come to know these are myeloid. Then coming to the second row, so granulocytes here, like we can see that they have a spectrum for side scatter, like from what So
No, that's a
16,
spectrum for 16.
yeah, so
Sites are
spectrum for
low.
16. So
Yeah.
technically granulocytes should have high 16, but here like there's a spectrum for 16. For the next one, again, like
So
30,
in this one, the point is that their site scatter is lower. That's what the point they were making, because the spectrum for 16 can be seen in the maturing forms as well, and this is marrow.
okay.
Go
Okay.
ahead.
And then the next one, again, we can see that there is abnormally like increased 13 expression. It should not be like that as we have read in the previous plot. So there is abnormally increased 13 expression. Then in the next one, there is increased 64 expression. And in the next one, there is increased 14 expression. So these are all aberrancies. And these did, as in a reading we read that if there are like you're getting aberrancies on flow, those, and if you have 3 or more aberrancies on flow, you can diagnose like MDS even in the absence of morphology. So
So
that was about
I want to interrupt. So we used to just say in such cases in the flow cytometry, I mean, not used to, we just say that there is aberrant myeloid blast population, and then we would say that the myeloid population has aberrant expression of CD13, for example, low, and CD33, for example, low, whatever. So we will say that there is aberrant expression, but in the top line or in the end, we are not going to utter the word MDS anytime by flow. So despite that, it is very sensitive, like they were saying that 80% of the cases, but still we just say that abnormal or aberrant population is identified and then leave it at that.
okay, same at our institute.
Yeah.
Okay. All right. So coming to the discussion, they were talking about MDS. MDS is basically a clonal neoplasm, which is characterized a clonal neoplasm characterized by ineffective hematopoiesis and thus peripheral cytopenias. It is diagnosed by based on morphology features, which will show like dysplasias, and then by cytogenetics in conjunction with the flow cytometry. On flow cytometry, we see blasts if the case is associated with increased blast population along, and then also it's used to establish aberrancies. In like in old days, mostly it was to show blast, but nowadays, as we have been it's more to establish aberrances. And how do we establish aberrances? By comparing it with the normal pattern, as Akanksha was saying, that like you can run a normal or like have a normal for comparison. And they say that 3 or more aberrancies is suggestive of MDS, even in the absence of morphological features. The last line that you have highlighted. Then they said that there are 5 classes of antigenic abnormalities. I think these 5 classes, like if we remember, it's pretty good that then you would know what to look for, which is deviation in like if you will compare with the normal and there is deviation in antigen intensity expression in 10% of the cells of interest as in any others, then that is abnormal. Or there is abnormal homogeneous antigen expression on population of interest, like usually like for like 13 16, like we see like there is a pattern of expression. If there is just a homogeneous expression, that is a deviation. Or there is asynchronous expression of 2 myeloid associated antigen, that's why it's always important to see the pattern. Or there is aberrant expression of non-myeloid antigen at least 10% of population. Or there is granulocyte hypogranularity, which would be decreased site scatter.
So one thing I want to note here is that they are just saying 10%. So it's not that majority of the cells should have like aberrant markers. It's 10% is very little. Like there would be just a small population that has a partial subset that is positive for blah and blah. So that even is aberrant. That's something that we should remember. Go ahead.
That's a good point. Yeah. I remember when I started first, like that coming to that 10% of you like see superficially, oh, like flow looks fine, and then the attendings would look up at that, oh, see that subpopulation.
Yeah,
That is
exactly.
yeah, so yeah, that's a very good point.
That used to blow my mind in the fellowship so much. Oh my God. I was like, oh my God, I cannot do this anymore.
Yeah, I had banged my head a couple of times.
And MSK flow is so sensitive. There will be like it's tiny populations that they will go after, and then I would be like, okay, I've lost my mind.
Just a prank. Now you're comfortable with those.
No, as I said, I don't like myeloid. That's the whole reason I don't like myeloid.
Okay, then that's a journey. I'll take it as.
Yeah, exactly. Yeah.
Okay. So the take-home points we have discussed all, just the last 2 points. The greater the number of abnormalities, more specific a flow would be for MDS. And most important point, understanding the normal pattern is important because only then you can compare and analyze and like figure out that it is something is abnormal.
Okay. Anyone else has anything to add or anything else?
Actually, one question.
I can't hear you very well, Prerna.
So I want to know, since they are saying 10% cells, so
Yeah.
suppose if we are seeing a less number of cells, then do we need to capture extra events for that? Like in MRD, we
Yeah, I
capture a
mean,
lot.
you adjust the gate all the time. So if you think that the whole gate is not being covered or something, then you can adjust the gate and see if it is more than 10%. Sure.
Okay.
Okay. Anyone else has any questions or any comments to add or something? Okay, then we can go ahead. Good job, Nidhi. Like you are my star. Okay. All right. So let's see what they are showing here. Anyone wants to attempt this? Like you can take a minute to understand what's going on here. Okay. So Nidhi, Prerna, anyone?
I'm looking at the graph. Let me see.
Prerna, you were saying something?
I can start if.
Yeah, go ahead.
So in the CD45 versus side scatter, I think this green population with high side scatter is granulocytes. The intermediate is the monocytes, and the low side scatter is the lymphocytes. And the red population looks like blast.
Mm-hmm.
And, then they are showing variable 34 and 38 more. Like it's the 34 they are losing, they're gaining 38. It looks like normal only. So okay, then in 33, they are showing some uniform positivity.
Mm-hmm.
Then in this myeloid, there is this one, that green population, I'm thinking it is normal because it is showing the CD13 getting dim and then again becoming bright with CD16.
Mm-hmm.
So this red looks abnormal because it has increased CD13.
Mm-hmm.
Then the CD14, 16 is plot is supposed to be where it is the 16, the bottom one, the top one, I think it is abnormal.
Mm-hmm.
With increased CD14 expression on the granulocytes.
Mm-hmm.
Yeah, so here I can see that CD14 is increasing. The monocyte population is, yeah, I think the blue arrow, they are showing the immature ones because they are dim negative for CD14 and then they are becoming positive.
Mm-hmm. Very good. So I think that's the correct explanation of this. Let's read that. So upper left panel shows all viable cells. Upper middle and right panel shows blast gate as defined by 45 side scatter. Blasts are shown in red. Monocytic are the lower panels and monocytes in pink, granulocytes in green. Myeloid cells comprise of 2.2% of the white blood cells and show largely unremarkable immunophenotype with mild myeloid blasts, so largely unremarkable with mild immunophenotypic abnormalities that includes like increased and uniform expression of 33. Maturing myeloid cells account for majority of the cells and show dramatic immunophenotypic abnormalities, especially two parallel lines of myeloid maturation were seen. The minor subset, that was green arrow, was normal in maturation, as she explained very nicely. And then this right is more expression of 13. So shows relatively, just a second. Okay, so two parallel lines of maturation. The minor subset of the myeloid cells, green arrow, show relatively normal maturation, while major subset of the myeloid cells, red arrows, show abnormal maturation pattern with abnormalities including increased CD16, CD13, and increased CD14. Monocytic cells are expressed in increased. So over here, monocytic cells are also increased, and that was shown in the pink population. That's an increased We don't have the counts here, but still they are increased. 30% were monocytic cells in this one. There was left shifted, as she said, as she explained nicely. There was immature population that was having decreased 14. So over here, there is decreased 14, and we know that they have bright HLA-DR, comprising 5% of the cells. Concurrent morphology showed trilineage dysplasia, 5% blast equivalents, including myeloid blast, monoblast, and promonocytes. Concurrent cytogenetics had monosomy 7. The findings in conjunction with persistent monocytosis were diagnostic of CMML. All right. So that's that. So over here, they say there is a patient with new onset of fatigue. So they are coming to anemia, thrombocytopenia, and absolute neutropenia. So again, we have a pancytopenic patient here. Okay. The patient is also noted to have absolute monocytosis and has persistence for past 6 months. The bone marrow biopsy. Okay. So, all right. So CMML is myeloid stem cell disorder, defined in the 2008 WHO as overlap of MDS-MPN. And there will be persistent, so that's the definition, more than 3 months of absolute monocytosis, more than 1 into 10 power 9. Or also monocytes typically have 10% of the WBCs. So that's kind of a definition along with the dysplasia. So WBC is usually elevated. And this one, it was like neutropenia, but did they give us WBC count? They didn't give us. So they did not clearly say that WBC was elevated here, but there are other CMML cases, more of dysplastic cases in which the WBC will not be elevated, but most of the times the WBCs are elevated and there can be neutropenias. Monocytes will be elevated, so that's by definition, it should be more than 1 or more than 10% of the WBCs. And then dysplasia usually identified in 1 or more of the myeloid lineage. Blast equivalence, by definition, less than 20%. And so, of course, it's chronic. And then CMML1 having less than 5% in the blood and less than 10% blasts in the marrow. And less than that, no blast in the blood or less than 5% blast in the marrow, they will be like CMML 0. And I don't know why this is showing up. Okay, and then CMML2 in the blood 5 to 19 and in the bone marrow 10 to 19. And all rods can be present by morphology. Flow cytometry can aid in the diagnosis of CMML by confirming that there is monocytosis and demonstrating the immunophenotypic abnormalities of myeloid, monocytic, and maturing myeloid forms. So we, in our cases, again, we say the top line would be monocytosis with aberrant blah blah expression and myeloid forms expressing blah 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 and abnormally expressing blah blah blah. And then leave it at that. As noted in chapter 1, introduction with commitment to monocytic lineage, cells acquire. So there will be very high levels of 64, 33 HLA-DR with 13 and 14 expressed on the high levels in the case of mature monocytes. In patients with CMML, as compared to the patients with reactive monocytosis, increased percentage of monocytic cells have been identified in the marrow by flow cytometry. So much more than the reactive monocytosis. Although immunophenotypic abnormalities are seen in reactive monocytosis as well, these are usually limited to single abnormality or in rare cases, 2 abnormalities. And this group, they compared immunophenotypic features of patients with reactive monocytosis to CMML and found that monocytic cells were present at higher percentage. So that's 1 point, and also showed more immunophenotypic abnormalities. That's the second point. Immunophenotypic abnormalities noted in the literature include decreased expression of the monocytic markers. So including in the maturing myeloids 14, including decreased expression of, we know that HLA-DR is kind of very bright in the monocytes. So decreased HLA-DR, decreased 13, decreased 15, and decreased 36. So monocytic markers are decreased. Overexpression of non-lineage specific markers. So CD56. Although CD56 overexpression has been demonstrated in CMML in a number of studies, it is critical that expression of this marker not be taken to imply abnormality when seen in isolation, because CD56 is seen on monocytes in the reactive settings and is commonly seen in the marrow regeneration after chemotherapy. One feature that appeared in the separate patients with CMML from those with reactive monocytosis by the same study was expression of 14. Patients with CMML was more likely to have a subset of monocytes expressing decreased or moderate levels of 14 than either patients with reactive monocytosis or the normal controls. When considered together, the presence of monocytosis of 20% of greater marrow monocytes showing moderate CD14 and 2 or more additional immunophenotypic abnormalities was found to be 100% specific versus reactive monocytosis and 67% sensitive for CMML. That's a significant percentage. This decrease in CD14 expression likely reflects, and at least in part, a left shift in monocytic maturation with an increase in promonocytes and monoblasts. Of note, the clone of CD14 employed is of importance, as some clones detect a more immature monocytic stage, while others stain only mature monocytic forms. So over here, this group now demonstrated that MY4 epitope appears prior to MO2 epitope. Cells negative for both appear to be predominantly monoblasts. Cells negative for MO2 but positive for MY4 appear to be pro-monocytes, and cells expressing both appear to be mature monocytes. Wow. However, it should be noted that expression of both antigens can occasionally be seen on cells with the morphologic features of monoblasts. As CMML is a myeloid stem cell disorder, in addition to abnormalities seen in the monocytic cells, myeloid blasts and maturing myeloid forms may show immunophenotypic abnormalities similar to that described in MDS. In addition, collections of APDCs have been described in CMML, and I think they didn't give 123. Okay, that's fine. So PDCs can be seen in the CMML as well, and they have been recognized by flow cytometry as a population following the blast gate, as defined 345 side scatter and showing bright 123 and HLA-DR. And finally, this is important to note that although features on peripheral blood may suggest percentage of blast equivalents of less than 20%, consistent with CMML, a more immature component may be seen in the marrow. Therefore, bone marrow evaluation will be important to exclude AML with monocytic differentiation in any peripheral blood specimen where CMML is diagnostic consideration. So take-home points. CMML is overlap of MDS-MPN with monocytosis. Flow cytometry can assist in diagnosis of CMML by confirming an increase in monocytes and demonstrating immunophenotypic abnormalities on the monocytes, myeloid blasts, and maturing myeloid forms. If considering a diagnosis of CMML in the peripheral blood, it is crucial to recommend a bone marrow evaluation and to exclude an acute myeloid leukemia with monocytic differentiation. So I remember just now, Nidhi, your question that are you comfortable doing this on a regular basis? So I mean, as I said, I still struggle at some cases, but like I still do it. There are some people in private practice who don't even do a myeloid panel in case of MDS if there is no increase in blasts. So all they are concerned about is if there is increase in blast, like previously they used to do. And in private practice, they don't always do myeloid panels. They don't always report the aberrancies of the myeloid antigens, and that happens too. Like that's not completely unacceptable, again, in case of private practice. But that's not a usual norm in case of any good practice or any university programs, because usually they are better than private practices. So I mean, because I was in private practice for last 1 year, I know that the two people with me who were doing flow cytometry, like the two hematopathologists who were with me, both of them didn't used to add myeloid panels in case of suspected MDSs, and they would still go away with get away with that. So I was trained with this, so I tried to put the myeloid panel. I tried to evaluate all of that, but again, like those still those people who just care about the blast exist, and they don't evaluate for the aberrancies.
Oh, wow, that's surprising. I thought you myeloid panel in MDS.
Yeah.
Hello, hi. For cases of MDS, as you mentioned, we really in National Cancer Institute or the tertiary hospital, the MEM specialist hospital. In both cases, we do not do for MDS except in increased number of blasts, because up to the moment, no, the WHO or nothing of the research groups like those of the Euroflow or even Brentwood, they didn't put like it is a diagnostic tool. It can tell you there is a limit of aberrancy, but actually the WHO they stuck with the cytogenetics, not with the flow cytometry. For cost effectiveness, if you do an AML panel, it cannot be diagnostic. It will not lead you anywhere. So it just help you that is yes, an MDS, but again the cytogenetic is the core for cases of MDS. So for cost effectiveness, it is not advised to do AML panel with MDS, except if the number of blasts is really increased and you cannot judge the number correctly. Maybe the flow cytometry will get you an upper limit or a higher number, so that it will lead you to say it's the patient in transformation. Otherwise, if the case is like 1-2% blast with obvious dysplasias, it's preferred that you go to the morphology and the cytogenetics then for cost effectiveness do AML panel, but it's not advised.
Right. And actually, I mean, that does not come in the WHO definition too. Like if you see the WHO definitions, they call about dysplasia, they talk about cytogenetic abnormalities. They do not like bring the flow
And even
cytometry.
not only the WHO, even Euroflow or Brentwood, no one say it is maybe help you in diagnosis, lead you the way, but actually this erythropoiesis is you have to confirm the ineffective hematopoiesis, this erythropoiesis, this myelopoiesis, megakaryopoiesis, dysplasia that you will find in the lineages is most important, and definitely the number of blasts, because cases like in transformation, some of the clinician treat them as a case of AML already.
Right, exactly. Yeah, that's true. That's very true. And again, like I said, that nowhere WHO brings that in definition. But again, like they are saying that, I mean, in MSK, we used to even give like 1% abnormal myeloid blast population is identified. And but as I said, it's not a practice in some of the places.
Yes, never. Yeah,
And
definitely.
it is not like a wrong practice too if they are not doing
No,
it.
you can do it, but I mean, it is not diagnostic. So for the cost effectiveness, because the cytogenetic panel actually is huge, for good cytogenetic definition of MDS, the cytogenetic panel is really big one. So you just put it to the cytogenetics and put the cost also in cytogenetic rather than put it in a thing that you will not benefit, except if the cases is more exceeding 15% blast and more, that the clinician can tell that it is a case already transforming to AML and treat it as AML.
So yes, so yeah, I mean, as like that's the reason that the whole reason that many of the university programs and good places they do report it, because as we read in the Brentwood, it is significant. I mean, it can tell abnormalities in the, and it can tell the incipient cases, and they have to be followed up. So those are the scenarios when, like, if you
Yeah,
want to be
definitely.
more accurate.
All cases of MDS, it has to be followed up whenever the patient
No,
is
but
diagnosed.
if there is still no dysplasia, or if there is still no cytogenetic abnormalities, however, the flow shows that it is having abnormal expression or aberrant expression. So that you
Okay,
have
but
to report.
in this case, I advise you that you do a quality control with a huge number of bone marrow, normal bone marrow, and you have the maturation pattern for quality
Right.
control and detecting what you are really doing.
Mhm.
Otherwise, you would be biased by uh, maybe the flow, the control, the case itself. Some cases have adhesions, more adhesive, more fluorescent.
I know what you're saying.
For these
Yeah.
cases,
Yeah.
again, it is advised
Right.
that you are putting
That you have a
something,
better quality
you
control.
have to do a lot or not less than 40 cases. I'll advise you not less than 20, 40 cases of normal bone marrow with
Right.
the same panel that you are using for the AML, so that
Yeah.
you can see the maturation pattern and detect the abnormality that you are talking about.
Right. That's why many of the institutes, they run a normal every time if they are doing any case, because they want to know if there is anything that is missed, like in the quality control too.
Yeah, definitely. But
Yeah.
in one case, while moving, it is not like a PNH. You do a control with the case, but
Mhm.
actually, it is a case of maturation pattern. So in these cases, it's advised that you look a lot of number of cases, and with
Right. Yeah.
something like software like InfanSight
Right.
or something that you merge the whole files, so
Right.
it
Yeah.
gives you the right maturation pattern with the
Right.
difference from the person to person variation. Don't forget this.
Right. Yeah. Exactly. Yeah. That makes complete sense.
Yes. Okay.
Yeah.
Otherwise, put your money into the
Last
panel
part.
of the cytogenetics, which is huge
Right. Exactly.
actually in all cases.
Definitely. Definitely. I
Okay.
agree with that.
Thank you.
And as I said, like, just relying on the blast percentage, many of the places they do that, and it's not an unusual practice.
Yeah.
They
No.
do.
No. It is a common practice actually.
Yeah. Yeah.
Okay. Thank you.
Okay. Did we finish this chapter? Wait, let me check. Yeah, we did finish this chapter. Nidhi, you want to summarize?
Sure. It's so starting with the case, it was a 51-year-old man who presented with fatigue and bruising. On CBC, patient had thrombocytopenia, macrocytic anemia, and absolute neutropenia. So kind of like going to pancytopenia, though they don't say leukopenia, they have absolute neutropenia. A patient had absolute monocytosis, and which was persistent for 6 months. Then a bone marrow biopsy was performed, and we have bone marrow biopsy for flow for the biopsy. So on the flow, on the first one, we have like all the mature cells with lymphocytes, monocytes, and then the lymphocytes in blue, monocytes in pink, and granulocytes in green. And then we have blast population here in the red. Then on the second plot, we have blasts, which are 34 positive and 38 positive. Then we have 34 and 33 positive blasts. They are showing that like normal, uniform, strong expression of 33. Then coming to
So
the,
this strong expression of 33, that is uniform and strong, is aberrant over here too.
okay, yeah, that's right.
Mm-hmm.
Okay, then coming to the lower one. So we have basically 3 population in this row. One marked with green arrow, one marked with red arrow, and one we have monocytes. So one marked with the green arrow, that is normal myeloid maturation pattern. That is showing normal 13 to 16 versus the myeloid which is marked with red arrow. That is abnormal population and is showing increased expression of 13. Again, and in the second plot, then we have also have increased monocytes. Then in the second plot, in the next plot, the myeloid population, the one marked with the red, they are showing increased expression of 14. So that is abnormal. That should not have been like that. Then also in the next one, 14 versus HLA-DR, we can see that monocytes, like their number in general seems increased, and then there is a subset of monocyte population marked with this blue arrow, which is losing 14. So that's an aberrancy. So we have monocytosis, as from the history that monocytosis is persistent for 6 months, and the monocytes are showing an aberrancy with decreased 14. Then we have blasts, which are 34 positive, 38 positive, and strong homogeneous expression of 33. Then we have an abnormal myeloid population marked with this red arrow, which have increased 13 and increased 14 expression.
Yes, and these forms that have decreased 14, yes, they are abnormal, but they are more of the immature forms as well. So that's something that you have to keep in mind with decreased 14 expression.
Okay.
Okay, very good. Next.
Okay, so basically, if we put together everything, then they were saying then they're more on morphology, they had trilineage dysplasia, and there were 5% blast equivalents, and they had monosomy 7. And in conjunction with the history of persistent monocytosis for 6 months, they gave the diagnosis of CMML. That was based on everything, but based on flow, we had those findings. So let's come to the discussion of CMML. Chronic myelomonocytic leukemia, it basically comes under the category of MDS/MPN neoplasms, because it had monocytosis and then it had dysplasias too. For the definition, we should have more persistent absolute monocytosis. That persistence should be for more than 3 months, and absolute monocytosis should be more than 1 into 10⁹ per liter. And that is absolute. And for the percentage white, monocytes should account for more than 10% of the white blood cells. And dysplasia is usually identified in one or more myeloid lineage. Then we differentiate monocyte CMML into CMML1 and 2. CMML1 when based on the percentage of blast in peripheral smear and bone marrow. If for CMML1 there is less than 5% blast in peripheral smear and less than 10% in marrow. For CMML2, 5 to 19% blast in blood and 10 to 19% in marrow. And all rods can be present. And on flow cytometry, we would have monocytosis but then they are discussing about how to differentiate, how we diagnose on flow. There would be monocytosis, there would be abnormalities on myeloid blasts, and their abnormalities on myeloid blasts, monocytic forms, and on maturing myeloid cells. So monocytosis, then aberrancies on blasts, on monocytic cells, and then on myeloid cells as well. Then they talk about maturing monocytes as the normal. When the monocytes are maturing, in the next paragraph as noted in chapter 1, they acquire high levels of CD64, CD33, HLA-DRs with CD13 and 14. They are like expressed at higher level as they mature. Then they try to compare abnormal monocytes with reactive monocytes, because they say also the reactive monocytes can show aberrancies sometime, and even in reactive conditions we can see monocytosis. So how do you compare, like if it's a reactive condition where you can see monocytosis and some aberrancies? So some clues are as compared to the reactive in some CMML or another neoplasm, there would be more and persistent monocytosis. There would be decreased expression of monocytic markers, including CD13, HLA-DR, CD33, and 36, and 15. And there would be overexpression of non-lineage specific markers like CD56. But there is a caution here. Don't use anything alone, use this in conjunction, because we have seen that CD56 can be expressed in reactive settings too, and in regeneration after chemotherapy too. So always use it in conjunction with others. Most sensitive aberrancies, decreased expression of CD14. If this aberrancy, decreased CD14, is used in conjunction with 2 other aberrancies, then it has a very great sensitivity for diagnosing CMML. Then they talk about clone for CD14. There are 2 clones for CD14, MY4 and MO2. Then they compared
Do
about.
you have these clones? Do you have experience with these clones?
I don't.
Anyone else has?
For me, cases of chronic myelomonocytic leukemia, if there is no increase in blood cells and there is no cytogenetic abnormality and the patient didn't exceed 3 months, I was always put the comment that there is increased marked monocytosis. It is a case malignancy, chronic myelomonocytic leukemia versus reactive monocytosis. We have to include all the reactive causes and underlying neoplasm like T cell neoplasm, which have sometimes the same pictures. So we cannot put it if we don't have like resistance of the monocytosis and no increase in the blood cells and no cytogenetics. So we cannot put it like we cannot put it chronic myelomonocytic leukemia. We have to put it versus reactive for close follow-up.
Right, that's more practical point over here. And I mean, as I said earlier, for the MDS cases as well, I mean, some places they still say that there is aberrant or abnormal population that is identified, and some places just leave it like that there is monocytosis, and then you have to rule out all the other conditions that can have monocytosis. So I mean, those both the practice, I would say that they are fine. And over here they are saying that aberrancies of the antigens along with decreased CD14 and the others, they are saying they can detect the reactive monocytosis versus the abnormal monocytosis, and then 67% sensitive. So again, we are not going to say conclusively that it is CMML.
Yeah. I put it in the diagnosis like case of monocytosis, and go back in the comment saying that this case have abnormality or the dysplastic monocytes, but cases are like this, and we have to have close follow-up in the upcoming 3 months
Exactly.
until there is persistence and no other neoplasm arise.
Yeah, that's a perfect approach. Yes. Okay, go ahead, Nidhi.
Okay, so yeah, they are talking about the clones, although I don't think like anyone, at least
No one does it.
yeah.
I would not even read it. Like, I don't think that, like, I don't know if no one, I should not say no one, but at least I haven't seen wherever I have went. Okay, go ahead.
Okay, then they talk about like we've read earlier too, that there is expansion of plasmacytoid dendritic cells in CMML, and those plasmacytoid dendritic cells are like usually in the blast gate, and they have bright CD123 and bright HLA-DR. Then another important point they made is that always do bone marrow in cases of CMML, because sometimes, like, even though the blast would be less than 20% peripheral smear, if you do the bone marrow, there may be more than 20% blast, and the case can go to the acute leukemia category.
Perfect. Okay. All right. Anyone has any additions, points, or any questions, comments? Okay. All righty. Okay. Anyone wants to take this one? This one looks like a little bit straightforward. Little bit. I would refrain. Okay, I'm giving a hint, but I would refrain from reading this. Okay, Prerna, Nidhi, anyone wants to try to attempt this one?
I'll try.
Yes, please go ahead.
So in the CD45 versus side scatter, I feel the green ones are the granulocytic cells, the orange ones are probably eosinophils, the pink ones are monocytes, the blue ones look like lymphocytes, and these purple ones, I don't know, maybe basophils, and the red ones are blast. So in this 16 versus 13, it's a slight abnormalities there, because CD13 goes a little more dimmer than.
Actually, first thing that you should see over here, that it is a peripheral blood.
Okay.
And you're not supposed to have this population in the peripheral blood. Go ahead.
So that's a left shift, basically.
Yes, exactly.
It's are there, and there is a little bit increase. 13 is here. And then this next plot, there is a small population which is showing some CD56 expression. granulocytes in the 34 versus 38. I think the red ones are the blast, and they're showing variable, like they're showing that same like the previous case. CD34 is decreasing and 38 is increasing. So I'm thinking the more or less it's normal expression pattern. Then 38, there is a population that is purple. What was those basophils? I think. Showing some CD38 positivity, and these cells are 123 positive, then HLA-DR negative. The blast is showing CD123 negativity and HLA-DR positivity. I am not sure whether these blasts are showing some CD7 positivity, but they are positive 30, and these basophils are negative for 34 and stuff.
Right. Very good. Excellent. So that's what this is showing. And the major clue to this one is the left shift in the peripheral blood. So that's, we see that in the, okay, but what's your clue? Like, what's your diagnosis again?
There is eosinophilia, there is basophilia, then there is left shift. So I think CML.
Yeah. So what will be your top line? How will you report it? Sorry, I'm grilling you. I should not do that, but you are the only one speaking. So.
Okay. Probably I would just call it MPN.
MPN, okay. All right. I would not, I mean, everyone has a different kind of practice, but I would not call it maybe MPN just based on flow. I would just say that there is a left shift, myeloid left shift, basophilia, and report the percentage of basophilia, and abnormal expression on these myeloids of 56. And the counts and the bone marrow and peripheral blood and the morphologic evaluation basically, and the CBC and everything, I would leave it to that for CML. But in all practical purposes, you are completely correct that it is having all the features of CML. And if you want to say that it is MPN, I won't say that you are wrong. So, yep. All right. So very good. You explained really, really well. So, I mean, I don't think that I need to explain again. You really covered everything. So, flow cytometry of the peripheral blood. The upper left panel shows all white blood cells, and upper middle and right panel show myelomonocytic. The myeloid cells are in green and the monocytic cells are in pink. And eosinophils in orange. The lower panels all show a blast gate, and as defined by 45 and site scatter. And flow cytometry of the peripheral blood demonstrates myeloid predominance, that's in the peripheral blood, with increase in CD34 blasts. So this should not happen in the peripheral blood as well. So again, that will be coming into our top line as well. So 3.5% of WBCs in the peripheral blood, that's of WBCs are the blasts. And then increase in basophils, that's what we are going to report as well. The myeloid cells show prominent left shift. That's what we are going to report, illustrated by 13. So this is presence of these cells. So ideally, the only 16 positive granulocytes should be present in normal cases, but you can see this typical immature blasts, and then promyelocytes, myelocytes, and then the other forms. So the mature forms. So this should not be there. So prominent left shift, as illustrated by 13 versus 16 dot plot, and shows unusual pattern of expression of 13 and 16 with an angular pattern rather than the smooth curve with normal myeloid maturation. In addition, the normal subset, a small subset of maturing myeloid forms co-express the 56. It should be noted that immunophenotypic alterations present on maturing myeloid forms in this case are subtle and not diagnostic of myeloid stem cell disorder in isolation, because similar findings can be seen in maturing myeloid forms in case of active regeneration and GCSF stimulation. And the basophils are defined by 45 versus site scatter in conjunction with expression of 123 without HLA-DR. So again, the expression of 123 can be seen in the PDCs as well, but there will be bright HLA-DR in case of PDCs. So expression of 123, and I want to highlight this and it's not highlighting. Expression of 123 and with no HLA-DR those are your basophils, can be easily separated from 34 positive blasts on the basis of immunophenotype. The blast in this case show minimal abnormalities. So there was expression of 7 on a minor subset and variably reduced CD123. Strong uniform expression of HLA-DR. Similar to the immunophenotypic alterations noted in the maturing myeloid forms, the abnormalities in the blasts are subtle and not diagnostic in the isolation. However, combination of markedly elevated WBC count, left shift, mild immunophenotypic abnormalities in the myeloid blast, maturing myeloid forms in context with basophilia is suggestive of myeloproliferative neoplasm and raises the possibility of CML in chronic phase. PCR, so again, you cannot say that it is chronic phase just based on flow. I mean, yes, the blasts are less than 5%, but again, the evaluation of bone marrow is the one that you are going to go for. PCR studies performed in the peripheral blood demonstrated the presence of translocation 922, in this case, confirming the suspected CML. Perfect. All right, so over here, they are giving a case that has abdominal pain. So we know that the splenomegaly is one of the features of CML, prominent features. And then that started after fall. And then he notes fatigue, poor appetite, and early satiety. And the physical examination is noted to have severe abdominal tenderness and distension. Lab tests and abdominal imaging are performed, abdominal imaging. CBC shows WBC count of high, very high. WBC consisting most mature neutrophils and myeloid precursors with less than 5% blasts. CT scan demonstrates a massively enlarged spleen, evidence of intrasplenic hemorrhage and intraperitoneal blood. The portion of the peripheral blood is sent for flow and the PCR for BCR-able fusion. Okay, so CML, chronic phase BCR-able positive is the diagnosis. CML is myeloproliferative neoplasm characterized by proliferation of mature. This book is really good. If I would have, I mean, in our book, we are going to also give the sample reporting of each case that we are going to show, so that like people have idea of how you're going to report that particular case. For example, you're not going to just say this in your diagnosis, you're going to report it entirely differently. Chronic myelogenous leukemia is myeloproliferative neoplasm characterized by, of course, this will be your diagnosis and bone marrow after the BCR-able is they are done, and after it's established that it is in chronic phase. CML is a myeloproliferative neoplasm characterized by proliferation of mature and maturing myeloid elements. This is a diagnosis that is generally suspected on the basis of peripheral blood findings, myeloid hyperplasia, left shift with basophilia, but requires a confirmation of BCR-able, usually by PCR or by FISH demonstrating 922. CML is usually diagnosed in chronic phase, but can progress to accelerated phase with increase in blasts and increased basophils and or cytopenias, cytosis or splenomegaly unresponsive to therapy. Without treatment, CML will invariably progress to blast crisis, which, as CML is a stem cell disorder, can manifest with either lymphoid or myeloid blasts. The role of flow cytometry is somewhat limited in CML and has been traditionally been restrained to blast enumeration and lineage assessment in case of blast crisis. However, several characteristic flow cytometric findings are typically seen in the peripheral blood, and abnormalities of blasts and myeloid maturation can be noted in the flow cytometry, even in patients with chronic phase. However, the findings of CML are non-specific and overlap significantly with those seen in the other myeloid stem cell neoplasms, such as primary myelofibrosis. Therefore, peripheral blood counts and flow cytometry may suggest CML, and demonstration of BCR-able will be required for definitive diagnosis. Flow cytometry of the peripheral blood in CML reflects the characteristic morphologic findings. Myeloid elements predominate and typically show a prominent left shift in maturation, with distribution of myeloid elements in peripheral blood specimens from a patient with CML, recapitulating that seen in normal bone marrow specimens. So basically, it will look like a bone marrow. This is all the left shifted population. And then this finding can be illustrated when simultaneously examining antigens showing varying expression of varying levels of expression with maturation, such as 13 and 16. Additionally, immunophenotypic abnormalities may be noted on maturing myeloid forms. It will include aberrant expression of 56, retention of 64, abnormal pattern of expression of 13 versus 16. Basophils will typically be increased, usually more than 1% in the marrow, more than 2% in the peripheral blood, with a range of 1 to 41% reported in one of the studies. Basophils can usually be easily separated from myeloid blast with bright expression of 123 without CD34 or 117. However, in some cases, these markers, more commonly 117, may be expressed in subset of immature basophils. Such immature basophil population are more commonly reported in the disease acceleration in CML. An increase in eosinophils may be seen in these cases as well. Blasts may be seen in blood on bone marrow, will be less than 5% in the chronic phase. Blast may however show immunophenotypic abnormalities similar to those described in the other myeloid stem cell disorders. Of note, occasionally small populations of B lymphoid blasts with immunophenotypic abnormalities may be seen. If an abnormal immature B cell population is present, it is critical to exclude the possibility that the patient has a lymphoid blast crisis. If the blast percentage determined by morphology or flow cytometry exceeds 10%, basophils exceed 20%, care should be taken that it has progressed to accelerated or blast crisis. As CML is a stem cell disorder, blast crisis may be myeloid, 70%, lymphoid, 30% of the cases, usually B lymphoid. And as has been noted, flow cytometry is critical in establishing the lineage of the blast population. Occasionally, blast population with ambiguous lineage may be seen. Therefore, a thorough immunophenotype is required for the evaluation of CML and blast crisis. In chronic CML, so take-home points in CML, flow cytometry of peripheral blood will show left shift in the myeloid maturation, basophilia, with or without eosinophilia, and abnormalities on the myeloid blast and or maturing myeloid forms. The findings of CML in flow cytometry are non-specific and will overlap with the other myeloid stem cell neoplasms. Therefore, the diagnosis should be suggestive on the basis of morphology, flow cytometry, and definitive diagnosis will be definitely by genetic confirmation. Flow cytometry may be useful in assessing for disease acceleration, as this is often accompanied by increase in the blasts and basophils, more than 10, more than 20. In cases progressing to blast crisis, flow cytometry is critical. Okay, so that's that. Anyone has anything to add and anything to say?
For me, the cases of CML in the diagnostic, I do acute leukemia orientation tube to check the number of blasts and the lineage of blasts. But actually, having a left shift, or I can see it with morphology, this is not, it's irrelevant. I think having the acute leukemia orientation tube, knowing the lineage of this blast is the most important, even to follow up. And we just again put the cost effectiveness on in the beginning. You have to do cytogenetics and molecular at the same time. Again, with imatinib resistance, if you want, because of the old generations of TKI. So in the beginning, I think for me, I do the acute leukemia orientation tube to see the lineage of the blood cell and the percentage, but without going into maturation or basophil, because this is coming with the morphology, not with the flow cytometry.
Exactly. Yeah, that's completely true. And you are not going to, like, those findings you are going to report in your flow, but
No.
you're not going to say that it is.
It is irrelevant. It has no meaning. It has no meaning. If you say left shift with flow, I'm not say it will be like something make people laugh at it. No, I will never do that. I will never put it a report. I only put the number of blast count according to the flow, but the morphology is the key. The morphology is our key, but it is about the lineage of this blast. That's
what
all.
kind of lineage they have.
Yeah, exactly. Otherwise, there's no meaning of having basophil, having eosinophil, having whatever. Basophil increase in cases of sinusitis, so that it's irrelevant. All of this is irrelevant. Yeah, I think Brentwood in all of this is just this is more into doing into deep for research and knowing all.
I don't think so that it is just for research, because as I said,
so he's
in
doing
many
it
of
in the practice. I don't know if it's a
we
real
do in
practice.
practice.
Left
We
shift
do in
for
practice.
CML. You
No,
put a left shift in report.
Again, as I said, nothing of this is conclusive, but if there is all of these findings, we are going to report all of these findings in our flow cytometric reports, and we are not going to say that it is consistent or suggestive of anything, but at least we would tell that this is the abnormality that we are seeing by flow, and this is not a uncommon like practice. Of course, like in smaller places and private practice, that will definitely be not done, but it's not an uncommon practice to be performed in good institutes, and like the bigger institutes, they do perform all of these practices.
I don't know, but actually I don't know what's the meaning of bigger places, but NCI and the one
No,
you're talking
I
about,
understand. I'm not talking
both of
about,
them
I
are
don't mean
bigger
to,
places. But
yeah,
what we do is, if you would want to do something, you do cytogenetic, the fish, the
right, agree,
molecular,
completely agree.
the imatinib resistance,
Right,
and at the
exactly.
same time you do CD34 and 117 on the section,
Mhm.
because we are talking here about MPS, so we want to know the number, collection of blasts inside the biopsy section, and
Mhm.
the mastocytosis in cases of increasing 117, because we are
Mhm.
talking about MPM. Otherwise, I don't know definitely what he is reporting, but I doubt a lot that anyone will put a left shift in a diagnosis for flow in cases of CML. We put the number of blasts, we put the
Mhm.
aberrancy of this blast, even if the count is low.
Mhm.
But I don't know, maybe, I don't know, for us.
I completely apologize about the big institutes.
Yeah,
I
yeah,
didn't mean to
no,
say
no,
that,
no, no.
but
I mean that both places, actually, most of the protocols are coming from American protocol, or like this. We
Mhm.
are following the
I
American
completely
way.
agree. Many places they don't do
Yes,
that. I completely agree with that.
we are following
Yes.
the American. They are the one who invented things. So, but I mean, if you see it with logistic point of view, put your money put in something that it will
Agree with that.
really
Yes, that will
make
be
a
making the diagnosis. Yes, yes,
difference. A
I
difference.
completely agree with that. Yes,
Putting
I mean
imatinib
that's
resistance,
not going to give you your
it's
diagnosis.
much better. The TKI resistance, if you even put it in the beginning, because this TKI, some of them some of them are resistant from the first shot. So I will put my my money in such a thing. So that's it.
Right.
Okay.
I
Thank you
completely
very
agree
much.
with that.
Thank
Yes,
you.
yes, I
Thank you.
completely agree with that.
Thank you.
And agreed, like this
Okay.
is
Thank
not
you.
that is diagnostic.
Yeah,
And
definitely.
yes, and this is not something that's going to really help you with much. But I
Yeah,
mean, the real
definitely.
diagnosis,
Everyone has his own style. Yeah,
yes,
definitely.
yes, exactly.
Thank
And
you,
then
dear.
even if you see the peripheral blood completely findings of CML, sometimes people don't like to say it's CML unless they say BCR-able. So
Yeah,
I mean,
definite, because there is an
yeah,
overlap.
right,
CML
exactly,
can show like
right, right,
polycythemia vera, can show like ET, can show
right,
like idiopathic
right,
myelofibrosis. So the
right.
PCR ABL is a diagnostic tool.
Exactly. And I mean, I have seen some of the people writing CML just based on the peripheral blood CBCPR, like the peripheral blood review that they say. And I feel like that should not be done, because the PCR able should be done for confirmation. So
No, we
I've
put
seen
it
all
like
the
an MPN for correlation with molecular and the fish.
exactly, exactly. Yeah, completely agree with that.
Thank you, dear.
Okay. Sorry. Okay, so um anyone else has any comments or questions?
I want to ask something. I mean, it may sound silly, but it's actually
No, no. Ask all the silly questions. I am all for silly questions. I might not have the answer for every silly question. So go ahead.
okay. So while we were studying the acute leukemias, one of the discussions, it was discussed that we don't comment on the blast percentage in flow cytometry because there's hemodilution, the erythroid, and everything that was discussed.
No, we do comment on the blast percentage. Like, we do not rely on the blast percentage on the flow cytometry, but we do comment in our reports. You get it?
Okay.
Like, for example, if there is bone marrow, that has blast percentage of less than 5% by flow cytometry. But the real blast percentage will be count on your aspirate differential, or else CD34 and 117 that you'll perform on the bone marrow, and that will be your final counts that you're going to report out. That will be your counts that will make your diagnosis. So flow cytometric counts are not going to make your diagnosis, but at the same time, it is kind of almost mandatory to report if there are blasts in the peripheral blood, or if there are increased blasts, or whatever percentage of blast you see in case of bone marrows. Get that?
Yeah, and there is one more thing I want to ask. Suppose if we are getting the blasts which are showing that lymphoid origin, lymphoid lineage they are showing, so will we report it as accelerated? I mean,
we won't, by flow, we won't. So by flow, we are not going to report anything. But if you see lymphoid blast crisis or accelerated phase with increased blasts that are 10 to 19%, yes, you're going to report that there is increase in blasts, there is increase in whatever basophils or any other features that are suggestive of accelerated phase, yes.
no, my question was that I know that the status is 922 and it's a CML case, and I'm getting lymphoid lineage blasts which are not reaching the 20% mark, or maybe not 10% in the bone marrow. Will we still call it accelerated phase or not? That's what I want to know.
You will still call it
Lymphoid
accelerated.
lineage is not supposed to be there. The lymphoid blast lineage is
No,
not
yeah. If there are blasts, see, the whole point here is if there are blasts by your aspirate, whatever it is, lymphoid, myeloid, if there are blasts in your aspirate that are 10 to 19%, that is your definition for accelerated phase, and you're going to report that this suggests an accelerated phase. Doesn't depend, doesn't matter if it is lymphoid blast, doesn't matter if it is myeloid blast. More 10% to 19%, yes, that's it.
Okay. Because I read somewhere that if you are seeing lymphoid blasts is basically accelerated phase because the lymphoid blasts are not supposed to be there. I don't remember
Exactly, exactly. Lymphoid blasts are even more specific. For example, in regenerating marrows, you can see an increase in the myeloid blast. But again, I mean, if you're seeing an increased myeloid blast or lymphoid blast should not be there, as you said. And you will have to report that it is, for example, 12% or 15% blasts that are identified with lymphoid immunophenotype, and that is concerning or suggestive, whatever you want to like write in your report of accelerated phase.
Okay.
So I think I would like to add to that,
Yeah,
like
Dr. Gupta.
whatever
Yes.
Prerna is saying.
Yes.
That is the only valid indication for doing flow in CML these days. That you want to know the lineage, because in the latest WHO update only they have said, like, if they are lymphoid blasts, then there may be an imminent blast crisis.
Right.
And that is what the clinicians are interested in knowing. Other than that, many things, like most of the things will be done on morphology and cytogenetics.
Completely agree with that. Yes. Yeah, lymphoid
So
blasts
maybe
are
they
more.
can write a, yeah, sorry.
Please go ahead. Sorry, I didn't want to interrupt you. Please go ahead.
So regarding the discussion we had like before this regarding this CML flow, in this chapter, maybe they can mention a comment that this was done by chance, or if you happen to do a flow on peripheral blood and a suspected CML, this may be the pattern you see. Like, this is not a common indication for doing other than the lineage of blast. This is what we also usually follow in our practice.
Got you.
Unless we are interested in knowing the lineage of blast, we don't advise to do flow
for
of CML.
peripheral blood flow. Got you. Yeah, we kind of do the peripheral blood flow despite if it is suggestive or like conclusive of CML even. But I agree with that. Like, I agree with that rationale. That sounds reasonable too.
And one more point I would like to add before the discussion we had on MDS is, like, again, if the blast percentage is low and we like to document all the aberrancies in our settings, like in Indian settings, it is very common to find these aberrancies because of associated B12 folate deficiencies and chronic infections like tuberculosis, alternative therapies, drugs patients are taking. So a
I
lot of things
completely
have to
agree
be
with that.
ruled out
Yeah,
before
yeah,
we
I
comment that
completely
these
agree with that.
aberrancies may
This
be
is
suggestive of
absolutely
neoplasm.
correct. Yes, and not even in Indian settings. I don't think that it is just in Indian settings. That's a phenomena that's why we don't commit to anything. Like we just say that they are aberrant and leave it at that, and the rest of the things will be done by morphology and cytogenetics. Absolutely correct.
Yeah, a lot of clinical correlation. Like unless
Yeah,
they rule out everything clinically, it is very
yeah.
difficult to pinpoint that it's
Our
neoplasm.
magic word is clinical correlation is recommended.
Correlation. Yeah, that saves us all the time.
Yeah.
It may seem escapist, but actually that is the way.
No, that's the way to do. I mean, that's not wrong. That's the way to do it. We cannot just completely like say based on what we see. It's all correlative medicine.
By the way, cases of vitamin B12 and folic acid deficiency show pictures and even C viruses. I don't know if you saw a lot of these C viruses, autoimmune diseases have
Right.
dysplastic features and they
Right.
are disaster in the bone marrow,
Agree.
especially vitamin B12 and folic acid. They
Yeah.
are in the bone marrow, they are really disaster. So,
Agree.
so
Yeah.
the nutritional profile is a must in such cases,
Yeah.
and really the clinical and the correlation with all the investigation is
Right.
mandatory, except
Right.
if there is a increase in number of blast cells. Otherwise, this increase in number of blast cells put us in another category. Otherwise, it has to be correlated with the very good nutritional
Cytogenetics
profile,
and
autoimmune profile, and viral profile as well, because C virus do a lot.
yeah, we have kind of a common big comment that we kind of put in all the cases where we see dysplastic changes where the cytogenetics is not performed, and we say that though it can be seen in MDS, but there are other things, as you said, that these dysplastic changes can be seen, and the final confirmation, unless there is increase in blast, the final confirmation should be based on cytogenetics and stuff like that. Some of the institutes, they like to say MDS right away, but I don't do that. I mean, I am not that confident, or I don't think that's the good practice to do for
Okay,
myself.
for the lady who asked about the number of blasts for the flow cytometry versus the morphology, you were right. Actually, yes, we rely on the morphology for the number of blasts, but in very rare cases, I show a discrepancy between the flow
Yeah,
number and the number of blasts, and this is because of dilution factor. You
right.
think that the number is really good, or the morphology is not that much diluted, but you don't know what is the real one. So
Right.
sometimes the flow cytometry get higher number. In these
Mm-hmm.
cases, we say that the number of bloods, but they have to express CD34. Okay, in these
Mm-hmm.
cases, in this very low number, we say there is
Mm-hmm.
discrepancy, and this discrepancy coming out and the number of blasts coming from the flow cytometry is higher, and this
Sure.
discrepancy is mostly coming from dilutional factor while spreading
Mm-hmm.
or something like this. But
Right.
we have to comment if the number of the flow number
Higher
of
than
blood
the,
is
yeah.
higher.
Yeah.
We put the number of the flow, but we
Mhm.
have to put the comment that there is a dilutional factor
Right.
that have raised this discrepancy, because we lose the blast in the flow cytometry. We lose the
Mm-hmm.
blast. We lose the cells because it's fragile. But
Mm-hmm.
having a higher number in flow, it is sometimes because of dilution as well.
Right, completely, yeah, that's correct.
Mm.
And sometimes in this scenario, if there is a good biopsy, I mean, sometimes the biopsy also doesn't help, but
Definitely.
if there is a good
Definitely.
biopsy, then 34117 can
Yes,
come for it.
CD34 is great in cases
Yeah,
of acute leukemias, and even in CML, it is very important because
yeah,
many
agree.
cases there is collection of blood and it is not seen in the bone marrow.
Right, exactly.
Aspirate.
That happens,
But you
yeah.
can see the collections in the
The
biopsy,
biopsy.
and you have to comment there is a collection of blood. Sometimes you put it as a chronic phase, how the patient is going to acceleration phase.
Yeah,
But
yeah.
it's so much with the CD34 collection of blood cells in the biopsy. So it is a routine to do CD34, do CD117 in
Right,
cases
right,
of CML in the biopsy.
right, yeah. I agree. I mean, in fact, in case of even suspected MDS, I just throw in the 34117
Yeah,
myself.
definitely.
Just to,
Even us, we put
yeah,
CD34 in all cases. And it is
yeah,
like
yeah.
all MPN cases,
MPN
all
cases, all the myeloid cases, basically. Yeah,
MDS cases.
yeah,
We
yeah.
just do CD34. It's a must, but we add CD117 in cases of MPN. Yeah, exactly.
Yeah. Okay, Nidhi, ready to summarize?
Sure. Okay. Before starting summarization, I was just reading the accelerated and blast phase criteria from WHO just to clarify some points, if that's okay.
Yeah, sure.
Okay. So as we have been discussing for accelerated phase, we need like I'm just discussing about basophils and blasts. For the basophils, more than 20% basophils in the peripheral blood and 10 to 19% blasts in the peripheral blood and / or bone marrow. So now WHO gives 3 caveats to that. First is, as I think Prerna was mentioning, the finding of bona fide lymphoblasts in the peripheral blood or bone marrow, even if less than 10%, should prompt concern that the lymphoblastic transformation may be imminent
It's
and warrant
imminent, yes.
further clinical and genetic investigation.
I,
as we
in fact,
discussed.
remember reading this from in our
Session.
home the Impact Book Club. You remember? I mean, we
Yes,
read
I
book and
do.
yes.
That's why I just quickly grabbed the WHO.
Yeah.
Okay. Then another point is, which we know, more than 20% blasts in peripheral blood or bone marrow, or an infiltrative proliferation of blasts in an extramedullary site is diagnostic of blast phase. So more than 20% blast, and then also infiltrative proliferation of blasts in an extramedullary site. That is also diagnostic of blast phase. Then the third point is large clusters or sheets of small abnormal megakaryocytes associated with marked fibrosis in bone marrow in biopsy specimens may be considered evidence of accelerated phase, although these findings should be used in conjunction with the others.
Right. Yeah.
And then also for the blast phase, for the blast, we have discussed that the blast phase can be lymphoid or myeloid, but they say the blast lineage could be myeloid, and when it is myeloid, it can be anything: neutrophilic, monocytic, megakaryocytic, basophilic, eosinophilic, or erythroid. Although, like, I haven't seen, but WHO is mentioning. And then for the when it is lymphoblastic, it could be T or B. And then I think, as Dr. Gupta said, like flow cytometry, WHO is saying, is the preferred technique for phenotypic analysis in order to detect like any in order to detect blast lineage. And sometimes we can even have like mixed lineage and blast.
Right.
So
Analysis, yeah.
flow cytometry would be a big help there.
Yeah, just for the lineage analysis, like Dr. Gupta was saying. Yeah. Okay, perfect. Very good. All right.
Okay, so coming back to our case. So we have from the history, we have a 56-year-old man who, sorry for the noise, I think something is happening in the outside. A 56-year-old man who presented with severe abdominal pain after a fall. He had severe abdominal pains. First on ultrasound, there was splenomegaly, and then the CBC showed there was leukocytosis, very high WBC count, 4,500, and there was blast for less than 5%, and on diff, WBCs mostly consists of mature neutrophils and myeloid precursors. So that was the history. And then on coming to the flow, in the first plot, we have in the green, we have myeloid population. In the blue, we have lymphoid population. In the pink, we have monocyte population. In the orange, just above the green, we have eosinophils. And then where we expect usually, like we have red with the blast population, and just a little above that in the purple, we have basophilic population. Okay, so that's different population. In the second one, we have this. So this is a peripheral blood, first thing to note. And we should not be seeing this pattern of maturation. We should just be seeing mature cells. But here we are seeing this spectrum of population of myeloid cells. And even this spectrum is little weird, like not that, but there's subtle angularity to it. So there's basically, it's indicating that the myeloids, there's a left shift to the myeloid maturation. Then in the third one, these myeloid cells have an aberrant expression of, some subset has small subset has an aberrant expression of CD56. Then the next one, we are seeing two population. In the red one, the red is the blast, which are CD34 positive and CD38 positive. And then the purple ones are the we'll figure, these are like CD38 positive cells, so far CD34 negative. Then in the next one, are these 38 positive cells are also 123 positive. So we can see these are basophils, which are basically 123 positive 38 positive, 34 negative, and 117 and HLA-DR negative. Those are basophils. Then we have blasts which are HLA-DR positive. And then next we have blasts which are 34 positive, and very small subset is 7 positive, if any, and then basophils are 34 negative. So basically from this flow, we can just say like we have small increase in blasts, and those blasts have like very subtle CD7 expression. And then we have left shift in the peripheral blood, and those peripheral, the myeloid cells have a aberrant expression of 56. We have basophilia, and those basophils are like CD38 and 123 positive and HLA-DR and 34 negative. So basically that's what we can say from flow. And then combining it with the clinical history of splenomegaly, leukocytosis, then it's going toward MPN, but for the confirmatory diagnosis, we need to send for like cytogenetics. We need a BCR-ABL, BCR-ABL translocation for the confirmatory diagnosis. So coming to the diagnosis, coming to the discussion, CML. CML, as we know, is a myeloproliferative neoplasm, which is basically a peripheral blood diagnosis, but the confirmation is as by BCR-ABL diagnosis. On peripheral blood, we usually have like leukocytosis. There is left shift of myeloid cells with basophilia, and there could be increase in blast depending on the phase, less than, if it's in the chronic phase, less than 10%, if it's in the accelerated phase, 10 to 19, and if it's blast phase, more than 20%. Then also increased basophils with or without cytopenias or cytosis, and splenomegaly, all of these unresponsive to the therapy. Then role of flow. So we have discussed a lot about the role of flow. I won't go into too much details. Flow role is more about blast enumeration and to detect lineage assessment. And then they talked about, because here the peripheral blood will look like bone marrow, based like as we saw earlier. And along the clues, I'll just discuss that it's not diagnosis, but some clues would be that the peripheral, the flow would look like bone marrow, and there would be some immunophenotypic abnormalities. Some immunophenotypic abnormalities that they have discussed are aberrant CD56, retention of CD64, abnormal pattern of expression of 13 versus 16. Then they discussed that the basophils are increased. And then we have discussed already that what the basophilic pattern is, that the basophils are CD123 positive without CD34 or 117. That's how we differentiated from blast, not 34 or absence of expression of 34 and 117. Another cells that we should differentiate it from that we discussed earlier is PDCs. So basophils are 123 positive, whereas PDCs were 123 basophils are 1 HLA-DR negative, whereas PDCs were HLA-DR positive. So
both will have 123.
Both will have 123.
Okay.
Good. So that's that. Then they talked about like the blast type. So if it's myeloid, then definitely like for accelerated 10 to 19 and blast more than 19. For lymphoid blast crisis, like if we see any lymphoid blast, even if it's less than 10% or more than, like think of an imminent blast crisis and take the case from there. Then in general definition of accelerated phases, blast 10 to 9, more than 10%, and like 10 to 19%, and basophils more than 20%. For CML, when it changes to blast crisis, it could be myeloid, which is 70% of the cases. And as I read from WHO, those myeloid could be anything, or lymphoid, which is 30%. And when it's lymphoid, it's mostly B lymphoid. So that's that. And then take home points. I think take home point summarizes this chapter very well, like that there is a left shift, but the findings in the flow cytometry are non-specific and they overlap with the others, and everything should be taken in conjunction. And then flow cytometry is basically used for blast lineage assessment, and accelerated phases when in general, like I'm not talking about lymphoid or others, in general about when blast is more than 10%, basophils more than 20%. Yeah, that's all.
Very good.
Thank you.
Okay, so we have almost done 2 hours short of 7 minutes. Do you guys feel saturated? Or I mean, we have maintained a slow pace, we have maintained a good small, like it was not an express today like usual expresses, but do you want to first take a break and continue, or second, end and continue tomorrow? Don't message, start talking, man. Wait. Okay.
I'm
I
okay with either.
You're okay with, yeah, I mean, I'm okay with either of, so what are other people feeling? Say, come on.
I think I will be there with you. Thank you very much. It's highly instructive, informative. Keep it up.
Yeah, I like it. I mean,
Keep it
I
up.
love
I
it.
like the discussions.
Yeah, I like this the sessions that have a lot of discussions too. That's why
Yes,
the cases sessions are most interesting, because there is a most discussion in the cases sessions.
exactly. That's what is very much essential and informative.
Yeah. Okay.
Thank you. Keep it up. Keep it up.
Thank you for joining, Dr. Iqbal.
Yeah.
What do you say? We have 16 people. What do you say? What, are you exhausted? Do you want to continue?
Depends
Say
on your
something.
stamina.
I'm okay with both. If you want to continue, I can be there as well.
Okay. Then let's take a 5 minutes break, and let's quickly do our things, and maybe we can go half an hour more, do one or two chapters more. Okay, sounds like a plan.
That sounds good.
I'm not going to close the Zoom. I'm just going to mute myself, and then maybe stop recording for next 5 minutes, and then resume the recording, and then resume the session. Okay.